Hello guys. So today again I am there with an integrated topic, that is the ocular manifestations of the inflammatory bowel diseases. Why did I felt that this topic should be done? Because there are so many places where we will be talking about the inflammatory bowel diseases. If you remember, we did talked about this in the acute anterior uveitis, which are presenting along with the arthritis, and it is other way round also. When you people read this in the medicine, in the surgeries, in the pathologies, there they are actually mentioning, about these ocular manifestations. So today I will be explaining these manifestations with respect to the inflammatory bowel diseases. So let's get started. First of all, meet him. He is the Burrell Bernard Crohn's. So you people know all about the Crohn's disease. So credit goes to this great personality who reported 2 cases with the ulcerative colitis. Now, if you look at the etiology of the inflammatory bowel diseases, there are so many etiological factors. We have genetic factors, infectious factors, and your immunological dysregulation, and important is your increased TNF alpha as well as the interferon neuron gamma. Okay, now if I see the extra intestinal manifestations, this will be helping you in so many places, because not only the eyes, but actually we have skin, you have ear, you have the skin, you have eye, you have joints, you have hepatobiliary system. Now, if I talk mainly about the ocular manifestations, they are occurring in 4 to 10% of the patients. So, less than 10% of the patients having the inflammatory bowel diseases will be having the ocular manifestations, and there are so many ocular manifestations: conjunctivitis, episcleritis, scleritis, keratitis, anterior uveitis, retinitis, we have vaso-occlusive diseases, even optic neuritis, and you have orbit inflammatory diseases. So what to learn? So the name is inflammatory disease. So in every part of the eye it is the inflammation, but specifically important are 3, that is episcleritis, scleritis and anterior uveitis. So you have to actually remember 3 very importantly. It is episcleritis, scleritis as well as anterior uveitis. Now if you look at these ocular manifestations, the risk is higher. The risk is higher in the patients who are having colitis as well as ileocolitis than with the ilitis. Now when they are asking these reason assertion type of questions, or they are asking you true and false kind of a questions, actually they are asking very minor details about the related disease. So that's why you have to keep note of this, that less than 10% of the people will have the systemic this ocular systemic association showing the ocular complications. Mainly is the episcleritis, scleritis and anterior uveitis, and the risk is much higher in those people who are having the colitis and ileocolitis in comparison with the ilitis. Now those patients who also have the arthritis, if I talk of the patients who are also having arthritis, they have 33% risk for the ocular involvement. Now if you compare, there it was less than 10%, 4 to 10%, and now it is hiking to 33%. So I think this is a big jump, and this shows that if the person is having the ocular involvement, that means the ratio of the people who are having arthritis is much more. Then 50% of the people have more than one ocular complication, and 68% of the patients with the ophthalmic complications, those persons who are having the ophthalmic complications have 68% chances that they will have at least one more extra intestinal manifestation. That means if a patient of inflammatory bowel disease is coming to me with an ophthalmic complication, I must send this person to a surgery referral or physician referral, because the chances of extra intestinal manifestations are pretty high. Now, the pathophysiology of the ocular involvement, the basic thing is that why at all ocular involvement is going to take place. The important thing is that it is actually the immunology which is responsible for it. So the circulating antigen antibody complexes. Now, this is again a very important MCQ. If you remember, in one of our quizzes, we had this kind of a question also, that what is actually responsible. I had even discussed in one of the case scenarios also that it is the circulating immune complexes or the antigen antibody complexes which is actually responsible for it. So, how it is taking place? When there is a release of antigens, these antigens are actually causing damage to the GI mucosa. Okay. Now, when there is a damage to this GI mucosa, they are getting the release of the proteins, they are getting the release of the microorganisms, and that is actually leading to the hyperplasia of the lymphoid system, and that is actually leading to the formation of antigen antibody complex, and there is a higher prevalence of the HLA-B27 as expected. Now, as we say that episcleritis was most common. Now, this again was a question that was asked by some of my students on Telegram. What is the most common ocular manifestation of the inflammatory bowel disease? A $1 million question. So, this is your episcleritis. Episcleritis is the most common presentation this patient is going to give me. Now, this episcleritis can be, nodular, it can be diffuse, it can be sectoral, or it can be any pattern. See, if you look at the pictures, this is the kind of pattern that you are going to get in episcleritis. Now, so many times I get this question also, how to differentiate between episcleritis, scleritis, conjunctivitis, uveitis. Now, if you remember, I have told you so many times what is the difference between the circumcorneal congestion as well as the conjunctival congestion. So, in cases of the circumcorneal congestion, the congestion is found all around the cornea, and ciliary pattern is going towards the fornix, and it is comparatively freer in the fornix. While in the conjunctival congestion, the congestion is starting from the fornix area, so you get a clear zone all around the cornea. Alright, so this is actually the difference between the circumciliary congestion that you get in cases of uveitis, that you get in cases of acute congestive glaucoma, and the conjunctival congestion that you get is simply in the conjunctivitis. Now, if I talk about episcleritis and scleritis, scleritis is much more severe. So, that will be giving you much more symptoms. The amount of association with the systemic diseases is again much more, the pain is much more, and the diffuse involvement is much more. That is the criteria to decide whether it is episcleritis or scleritis. So, if you see here, this is a kind of episcleritis presentation that can take place. Even this is, so this is involving more diffuse pattern, while this is your sectoral pattern of episcleritis that can take place. Alright, now see this, again an important thing for your MCQ, it blenches with the topical application of phenylephrine. So, when we give the epinephrine, it is blenching, that means it is again the episcleritis. Now, another important thing, how to differentiate it. So, if it is episcleritis, then what can be done? The vessels can be moved with the help of a cotton tip applicator. You take a cotton wick and you use its tip. So, okay. So, if you are trying to manipulate it, you are able to move the vessels with the help of this cotton tip applicator. Secondly, if you remember, I told you the pain. Now, pain is again a very important marker. Pain is much more severe in cases of scleritis, and especially at the night time, and it is so severe that the patient is usually awakened due to that pain. While if you see in episcleritis, it is mild to moderate. So, in cases of the diseases, how it can indicate the activity also. If the pain is much more, it is actually indicating the activity of that disease. Now, see this. If you see the episcleritis, see this is your nodular episcleritis. Can you see? This is your nodular kind of episcleritis, this area, right? While if you see this is clear cut, the diffuse kind of episcleritis. So, I hope now the picture is very clear. Can you see this? Diffuse, this is diffuse, and this is your nodular. Alright. Now looking at the treatment, to complete the topic we have to see the treatment also. It can be mild kind. In the mild when it is just idiopathic, you can give the tear drops, you can give just the topical NSAIDs, okay. But if it is going towards a moderate or the severe variety, you have to use the systemic treatment, you have to give the systemic NSAIDs, but topical steroids can work here. Now that is very unlikely that it is not responding, otherwise we may have to shift towards the systemic steroids as well. Plus a very important thing is must treat the underlying diseases. Now whenever we are reading the systemic associations in ophthalmology, that is also understood that you have to treat the underlying cause, because that is the main pathology that is responsible. So no matter how many times you treat the symptomatology, if you are not treating the root cause, obviously it won't improve. Then the second thing is the scleritis. So scleritis again can be occurring in these patients, but it is much less common in comparison to the episcleritis. The first important thing, it is less common. Deep, more severe pain, and as I told you that just from the symptomatology itself, just from the severity of the pain, you will get an idea that whether it is scleritis or episcleritis. The morbidities are very high in these conditions. 50% have an underlying systemic disease. So the risk of association of a systemic disease is much more in scleritis in comparison to episcleritis. Now this is a separate statement. The first thing was that the most common ocular manifestation of the inflammatory bowel disease was episcleritis, but if the patient is having scleritis, then there are more chances of the systemic association. How much? 50% chances are there that the patient has the systemic association, and obviously it requires the aggressive treatment. Now if you look at the scleritis, we can have anterior scleritis, that is anterior to the equator. We can have posterior scleritis, posterior to the equator. Anterior scleritis is more common, and posterior scleritis is much less common. Now in the anterior scleritis, it can be nodular or it can be diffuse. We can have necrotizing, we can have non-necrotizing, and it is the anterior scleritis which is a diffuse kind, which is the most common one. Now if you look at this is your nodular variety. This is your nodular scleritis, while if you look at the second picture, this is much more severe, this is your diffuse scleritis, okay. Now recurrent scleritis, now this is again important as far as your IBQ is concerned, image based question is concerned. This is your sclerotia perforans. This is actually scleromalacia perforans is important when there is so much of thinning of the sclera that it is just very near to the impending perforation. So that condition is called as the scleromalacia, and this is very important again with respect to your MCQ. It can also be asked as a image based question, right? Can you see this bluish hue from the sclera? This is actually the shining of uveal tissue because of the so much and severe thinning of the sclera. Alright. Now let us see the treatment of scleritis also. You are using the NSAIDs, you are using the steroids. Now these you were using in episcleritis also. You were using the causative treatment, but here we have to give more emphasis towards the immunosuppressive agents like azathioprine, or we can use the mycophenolate, mofetil, cyclophosphamide, cyclosporine. So obviously more severe, and therefore more severe treatment has to be given, as well as the causative treatment has to be given here also in the form of anti-TNF. So whenever you are treating the scleritis, your treatment should be more and more intensive because it is much more severe condition. Then the third is your anterior uveitis. Now anterior uveitis in detail. When it is just the iridocyclitis, it is the anterior uveitis. When we have involvement of the pars plana, pars planitis is the intermediate uveitis. When we have chorioretinitis, it is the posterior uveitis. Now if I concentrate on the anterior uveitis, it is presenting with the sudden painful diminution of vision. So pain, the photophobia, the ciliary muscle spasm, these are the things which are in dominance when you are talking about the anterior uveitis, and again they have an association with the Crohn's disease as well as the sacroiliitis. And when it comes to the sacroiliitis, it is the HLA B27. Again, association is very, very important. Now, when it comes to the type of uveitis, it is low grade non-granulomatous uveitis. It can even be insidious. And the three important data. Now, 60% of the patients will have recurrent anterior uveitis, 10% will have non-recurrent anterior uveitis, while 30% of the patients have the choroiditis or the panuveitis. This is again important information that you need to remember. Now, in total, if you see the presentation of the uveitis, scleritis and episcleritis, and if I have to grade it according to the severity, I will say scleritis, episcleritis and then uveitis. Now, episcleritis and uveitis, you know, they are interchangeable, but scleritis is obviously the winner there. Now, even we can have the optic neuritis in cases of the inflammatory bowel diseases. So, if you look at the neuro-ophthalmological manifestations, what are there? You already know that it is associated with iritis, vitritis, we have retinal vasculitis, we have choroiditis. Now, we can also have optic neuropathies because of the dietary deficiencies which are created by these inflammatory bowel diseases. We have vaso-occlusive complications. Now, this is again, you know, very surprising that this can also be occurring in a patient who is having Crohn's disease, or the ulcerative colitis. We can have hemiparesis, case palsy and the Hemianopia. Now, based on this information, they can again very well form an integrated question. Can you imagine a patient of Crohn's disease, ulcerative colitis and the symptoms like gaze defect or hemiparaplegia or hemiparesis, hemianopias are present. So, this is again very, very important. Now, this patient can even be presenting with keratitis. We can have subepithelial keratitis which can lead to infiltration. Mostly it is bilateral and symmetric infiltration that is again expected from a systemic disease is going to found. Now, the orbital complications. Now, it is just forming 1% of the proptosis. It can be presenting as an inflammatory syndrome. It can be presenting as an inflammation of the muscles like myositis. But the good thing is that it is responding well to the steroids. But there is a problem that you should always try to differentiate it from the orbital cellulitis, which is much more common in cases of children, and it is the most common cause of the unilateral proptosis in children, which can end up in the cavernous sinus thrombosis, again a very, very important ophthalmic emergency. As far as the retinal complications are concerned, they are pretty rare. We can have the vascular occlusions, the edema, even the serous detachments in the retina. We can have CRAO, CRVO. So, can you see here every kind of ocular complication is possible here, right from the detachments, then optic neuropathies, then we have CRAO, CRVO and even the cystoid macular edema in 20% of the posterior uveitis. Now, I will say this is again very important because from the last 3 years, they are continuously asking about the etiology of cystoid macular edema. In NEET 2020, they asked about the supraphysiological dose of which vitamin causes cystoid macular edema. So, this year they can ask which of the inflammatory bowel disease can cause the cystoid macular edema. There can be, cases of the retinal vasculitis. We can have the cases of cystoid macular edema. We can have the cases of central serous retinopathy, CSR. The management is mainly the steroids. We can give topical steroids, periocular steroids, systemic steroids, try with the NSAIDs, immunosuppressive agents, and don't forget the causative treatment. We can even have the patients presenting with the glaucoma. So, we can have the cavernous optic atrophy. Glaucoma treatment, I think you all know, we can start up with the topical treatment, we can go to the laser as well as surgical treatment, then we can follow the trabeculectomy or the filtration surgery. Even we can try up with the glaucoma drainage devices. The patients can also present with the cataract. Now, why cataract? Because there is a lot of inflammation. So, this patient can even present with a complicated cataract. And the other things are your endophthalmitis. A very, very important thing is your nutritional deficiency. So, this patient can have nutritional optic neuropathy, retinopathy, as well as the Wernicke's encephalopathy, because it is causing the deficiency of the thiamine as well as vitamin B12. Now, the cyclosporine in the Crohn's disease, that is also responsible for the optic neuropathy, ophthalmoplegia and the nystagmus, which again forms an important part of the question. Then if I talk about the anti-TNF alpha and the risk of optic neuritis, you should know that it is actually associated with the demyelination. And there are pretty 17 good cases which have been reported. So, you should actually know, because there is a trend now that they are asking about the ocular side effects of the systemic drugs. So, that time you should remember that it is actually related with the demyelination. The summary, now the take away message, very, very important. Episcleritis, scleritis and anterior uveitis are the most common eye manifestations of the inflammatory bowel disease. Ocular manifestations are common in those people who are having colitis or ileocolitis in comparison to just the ileitis. Treatment of underlying inflammatory bowel disease is often effective. Steroids, immunosuppressives, anti-TNF agents are used in the resistant cases, and cataract and glaucoma are the sequelae of uveitis in the IBD. So, hope you had like this session. You will be getting benefit and you will be able to solve much more integrated questions now. Any doubt, you are always welcome. You can always ask me at any of the social media platforms. Do follow us on the Insta, as well as be a part of our family on Telegram and the Facebook. We have a lot of motivational and academic stuff for you people, and any other thing that I can do for you, I will be more than happy to do it. Thank you and happy ophthalmology.